The KEYNOTE-522 trial was the first phase 3 trial to investigate the addition of an immune checkpoint inhibitor to pre-operative chemotherapy and to continue with the immune checkpoint inhibitor after surgery in patients with early stage, with stage 2 or stage 3 triple-negative breast cancer. The trial used what I would call the most effective chemotherapy regimen, so a combination of 12 weeks of paclitaxel carboplatin, followed by 12 weeks of AC or EC, and either all the way through with pembrolizumab as immune checkpoint inhibitor or with placebo. Then patients underwent surgery and continued either with placebo or pembrolizumab for another 6 months. The trial had two primary endpoints, a short-term endpoint with PathCR, and we presented actually here in Barcelona 5 years ago a significant and meaningful increase in PathCR rates by 13.6%. And a second primary endpoint was event-free survival, so the prevention of recurrences, which we presented a couple of years ago, that we reduced the risk of recurrence by about 35%. Now here at ESMO today, we present the long-term update. We have now 75 months, so just over 6 years of follow-up. And that's really important for triple-negative breast cancer, because in triple-negative breast cancer, we know that the majority of recurrences happen in the first 2 to 3 years. About 90% in the first 5 years. There's fortunately very little expected beyond 5 years. If you look at the event-free survival curves now with more than 6 year follow-up, they're plateauing. We see only a few additional events that have occurred since the year 3 analysis, now year 5 analysis. And the delta, absolute delta in terms of event-free survival is about 9%, from 81% to 72% with patients who only receive chemotherapy and placebo. The hazard ratio for event-free survival is 0.65. But the key new data here in ESMO is that we now finally have the overall survival data. And it's fantastic to see from a patient perspective that practically all of that event-free survival benefit is translated into an overall survival benefit. The hazard ratio is 0.66. That's at this early time point a 5% delta in absolute overall survival, but also means a reduction in the risk of death by about 34%. First time we've achieved this in triple-negative breast cancer, and it's also obviously meaningful as it means that we can cure a substantially higher number of patients. In terms of long-term safety data, there's no new signal. It's pretty much what we expected. And so our conclusion from the data now is we have a trial that's positive in both primary endpoints, PathCR and event-free survival, but has also now demonstrated a substantial benefit in overall survival, which is the key secondary endpoint, meaning that we reduce the risk of death by 34% for patients with high-risk early triple-negative breast cancer. The clinical impact of these data has actually already been implemented. What we call the KEYNOTE-522 regimen, so the regimen of chemotherapy and immune therapy, has become standard of care in many, I would say most countries across the world, has been approved, is the new standard. But the clinical impact is also that fortunately now we see substantially fewer recurrences in the metastatic setting, so we can cure more patients, and I think there's nothing more humbling than being part of that.